Okay, so I've been asked to try and kind of cover how you deconstruct clinical communication so that as any other skill, you need to break it down in its component parts. And just to give you a little bit of context, Deacon's made this new academic position of clinical communication and end-of-life care, reflecting that I'm a palliative care physician, if you like, in my clinical role. We've got this new centre with a horribly long name, but I guess the issue about that we're trying to convey is we actually want to work with organisations to change them at whole of organisational level. And there's our Twitter handle for those that are interested. And as you know, next year we've got a new standard coming that we're all going to be measured against. And what's interesting is previously it's been focused on process and systems like clinical handover, which are absolutely critical. But I have been very critical to the Commission and worked with Sue Ellen, who's the director of this standard, and saying it is predicated that actually the clinicians have got the requisite skills, which despite 40 years of evidence show they have not. And I think we need to be blatant about that. How do you operationalise process and systems when actually clinicians have huge variability in skills? I would suggest you read this fantastic document from the Chief Medical Officer in Scotland. You get the title, Practicing Realistic Medicine, and in fact the follow-up document is called Realising Realistic Medicine. But look at the top three: change our style to shared decision-making, personalised approach to care, and unwanted variations. Now, in a conference like this, I can imagine there's a lot of thought about unwanted variations. And I think when you look at the evidence for healthcare communication, the reality is evidence-based training shifts nearly everybody to the right. And in fact, the evidence would suggest that those on the left-hand side of the normative distribution curve shift more than those on the right. So everybody improves. But in fact, if you like, some people who find this a bit harder have the most to gain from if it's evidence-based. And I will say up front, that does not include an online module by itself. And in fact, my conversation with most organisations is if you want me to build an online module about health communication as a solo intervention, you're not talking to the right team, because there's no evidence that it changes practice one bit. It does when you combine it with other things, but not by itself. And maybe with avatars and things that might change. And of course, the other thing is you want to change the variation from person as they meet a variety of patients or family members, or when they do different tasks like shared decision-making, communicating risk, aiding recall, lifestyle modification. And we don't want a big, wide, fat distribution curve. We want it nice and tight within an individual, within a department, and within a hospital, because the variation is huge. We've just looked at 4 years of data for AFRA on complaints related to healthcare communication. Anybody want to hazard a guess what the commonest category of complaints that end up with the regulatory authority is for communication? Disrespect. 60% of all the complaints that got to the regulatory authority were about disrespect. And of course, if you look at general complaints as it goes to Health Insurance Commissioner or hospitals, about half of complaints. The group I work with in Denmark, they actually review all complaints, and when they look at the other half of them are probably mostly actually healthcare communication errors or issues. So we need to change this. But my colleagues in America have a really beautiful saying is, you don't fatten pigs by weighing them. So we constantly performance manage people, tell them not doing very well, that they need to improve it, and then we give them absolutely no evidence-based opportunity to get any better. We keep saying there's a problem, but we don't give them any opportunity to get better. So what I'm hoping that even in 15 minutes you'll think about is the biggest missed opportunity for teaching is if each of you said once a week you're going to teach about healthcare communication, and you had the evidence, and you had the nomenclature and the frameworks to hand, and you can talk the same language, we could really change healthcare. Because it's the only place we integrate knowledge, examination of procedures, reasoning, and communication. You think about what you do. Okay? I had a colleague of 35 years from interstate recently come to a course. We said, why are you here? She said, because my registrar had completely deconstructed my consultation in language that I had never heard before, and I was embarrassed. She said, I like the way you started off and negotiated the shared agenda. Then you asked 3 open questions. Then you asked a prioritising question. Then you did a periodic summary. Then you checked in. Then you paused. Then you responded in non-verbal cue. I thought it was really effective. She said, I had no idea I'd done any of that. Because the registrar was able to deconstruct what had happened. And you cannot teach this. Imagine trying to teach a procedure like putting an arterial line without a common language like anatomy or a common framework. And yet that's exactly what we expect people to do, pick it up intuitively. And of course the evidence is that they pick up some things but they can't differentiate. So if I saw Judy do a consultation and you asked a junior learner what's just happened, she would say, oh, Judy's lovely, that was fantastic. And I said, I know that, but what did she do? Oh, she's really lovely. And they just never move beyond that. They can't say, well, she started off with this and then she did this and then she did this. So it's impossible to deconstruct. Okay, we know they deteriorate over time. And even if you spit them out from nursing school, medical school, even with high-level skills, we know that after about 5 years, they've actually copied the people they see in the hospital. The hidden curriculum trumps all their education. So 3 opportunities to teach. Case presentation, which is how I was taught. So they can tell what I've missed or what I've got, but they can't tell why I got some things and missed others. And they can integrate knowledge and clinical reasoning. Role modeling that we do, unfortunately, is largely implicit. You try and pick up why was that really effective, but you don't know. But of course, there's opportunities to do that before and afterwards. I'm going in to break bad news. I want you to watch for this, this, and this, and then we'll discuss this and this afterwards. And particularly focus on how I use empathic statements and silences. So you can really maximize how you are as a senior role model. And of course, how often do you say to your learner, I'm going to come in and watch you gather information and see if I can give you some tips to improve that? I offer my learners that all the time. People said, I don't have time. I said, well, most patterns are picked up in the first 3 minutes. You don't need to watch them for 20 minutes. You can watch them for 3 minutes. So, can we flick to the video, thanks? So I had some sound issues with my codec, so I think our friends are going to help us here. I want you to watch the skills in this interesting clinical encounter. Thank you.
Is that tight enough? Why don't you do it once more? Go ahead.
Okay.
There you go. Good. Now you fixed it. What?
You came here to die, didn't you?
I like this place, and I love the people here. You know, if we were to put this apple down and leave it, it would be spoiled and gone within a few days. But if we were to take a bite of it like this, it would become part of us, and we could take it with us forever. Everything is on its way to somewhere. Everything. That's a good bite.
Thank you. Does anybody want to say what the key skill is that John Travolta did in his clinical consultation that I suspect 90% of the clinicians would not do? That turned the whole conversation around? So silence was certainly one of them. And do you know what the average effective silence is? In this concept of wait time that they discovered in primary school education? It's about 5 seconds. If you wait 5 seconds, they're 50% more likely to have the courage to ask a question in this case. But he did something just before that. So you notice when he was doing the thing with the car engine, and he's looking at the two of them, and he picked up a non-verbal cue and asked a very complex question, what? And then he had silence for 5 seconds, and then the kid had the courage to say, you came here to die. And then everything followed after that. You can talk about the metaphor of using the apple. Though you showed this video in Dublin to a bunch of surgeons and said, geez, I didn't get the bit about the apple. What was that about? And that's a really bad Dublin accent, by the way. So metaphors don't work for everybody, and you have to be careful in use. There's been some research. You have to be careful using metaphors. But nevertheless, it's very creative, getting at the kids' level. So I guess what I want to say, there's a language to this. There's 40 years of evidence. In fact, there's actually more evidence to this than some of the physical examinations we do. And I was going to ask you the question, what do you think the 3 key communication skills that increase time efficiency? Anybody, any idea? Now, any of you lots of time in your hands as clinicians? It's interesting, but what are the 3 key skills that create time efficiency in consultations? I've asked this in the audience, and it's interesting, not any group has banged them out yet. Well, I'll tell you, it's early, shared, negotiated agenda, a counterintuitive one, which is spotting cues and responding to them, and the third one, ironically, is building rapport, which is why one of the kind of frameworks is the 4 habits model. We spend the first 1 to 2 minutes of a consultation building trust, because people divulge stuff after that. And those are the 3 have been shown to shorten one. The cues one, on average, shorten a consultation by 10 to 20%. 20% when surgeons are doing it. Interestingly, 10% in primary care. So there's a language, checking and chunking, signposting, which is a structuring skill. In other words, making structure overt. Safety netting, I've given you some examples there. And then there's all this active listening. There's NURSE, which I'll show you, and SPIKES, which you may have heard of. And ICE, an explanatory framework for illness, what the patient's ideas, concerns, and expectations are. This is all published, all studied. We also know what to teach and how to teach it, but it's not getting into hospitals and organizations. And safety netting, the idea of, I'm going to give you this morphine for your visceral abdominal pain. Okay, that's jargon. 90% of the time it'll help. That's the normal approach. 10% of the time you'll feel nauseous. Everybody will get constipated, and some people will actually feel quite disoriented and muddled. This is what I want you to do if that happens. Which one do you think the patients trust if they get nausea? Second clinician, yet we rarely safety net. So here's NURSE, a way to deal with emotions. Here's SPIKES, which Walter Beale in America wrote about breaking bad news, but there's another version written by an author, Joey Clayton in Sydney. And I can provide the references to these. SPIKES we use sequentially. NURSES, it's just a framework to help us how we deal with strong emotions. And then there's a whole bunch of other micro skills that we need to learn. And this is how you teach it as educators, how you do this on your ward rounds, how you do it at the bedside. So we're just doing some interventions just to give you an idea of how we're trying to make a difference. We're trying to do a whole approach with an organization we're calling Not Your Thoughts Matter. That's training kitchen staff, receptionists, and the health professionals to change the nature of the consultation, running lots of evidence-based courses from 1 to 3 days. And you may have heard about the iValidate project we've done around end of life that I think was presented yesterday by some of my colleagues. And of course, what we really need to work out is how you do this for a whole of organization approach, how you change that culture, that implementation research. So I've rattled through fairly quickly. I'm just trying to give you a bare taster that you can deconstruct communication. You can teach it in your workplace, and that it's hugely evidence-based, just like any other part of healthcare. So I'm going to stop there and see if we've got any time for questions. Thank you very much for your attention.